I am Tanya Popovic, and I'm welcoming you to our CDC Public Health Grand Rounds. Our topic today is hypertension, detect, connect, and control. I want to bring to your attention that next month we're not going to have a live session, but we are having a rerun in a way, which is going to go via our website, but we will be going live again with cancer screening in July. We're right now developing a new round of sessions for the next 12 months, so I will let you know what those topics are next time when we meet. As always, here's a list of resources. I want to bring to your attention a new feature that we have just started a few months ago, which is called Beyond the Data. It is a very quick video segment between one of the speakers and either myself or John Iskander, which basically brings home the key messages in a very simple manner to the broad audiences. And you can watch it on our webpage as well. Here is a list of science clip selections that accompany our topic as always. And I have to say that this particular session has been one of those that reminded me of Dancing with the Stars. You know how people say that they always thought it's simple and then they spend hours and hours rehearsing. This one was really challenging because it seemed like everybody and his brother wanted to put their 2 cents in it to make it perfect. And when I usually don't allow too much democracy, this time, because of the importance of topic, we kind of allowed some people to chime in. I really wanted to thank Judy Hannon, who served as our program point of contact for her work with all of our speakers. And this was actually one of the most fun sessions to work on. At some wee hours of the night as well. Now, let me introduce our speakers. Two of them, Janet Wright and Peter Bash, have really worked extremely hard, and as of now, they are going to be known as Kim and Ingo. The other two speakers, Claudia, who is not here, who is with us virtually in Philadelphia and will be joining us by voice, and Mike, are going to be known like Kelly and Derek. And I think for those of you who might be living on the moon and not watching Dancing with the Stars, Kelly and Derek are contenders for the Mirror Trophy. So I wanted to say just a couple of words for those of you who may be interested in getting a little bit more resources about the Million Hearts Initiative that Janet is going to be talking about in a little bit more detail. Some of the interesting things, the Medical Reserve Corps is launching a Million Hearts Challenge, and it's engaging their volunteers to control blood pressure at the local levels. Recently, we had a speaker who said that following their college degree and medical degree, they wanted to get a high-paid job, so they joined the Medical Reserve Corps, and I was thinking, you know, how true. So here's an opportunity to do something good. The other one is go to the Million Hearts webpage, where you can have a number of useful videos that are spotlighting how two of the practices are getting more than 80% of their patients controlling their blood pressure. And when you hear the talk, you will see that 80% is a huge number. And finally, one that I really love is how to engage men, because we all know that women are all decision makers at home and at work and wherever. And so how to engage men in taking control of their heart health. And at 1 p.m. Eastern Sunday on June 3rd, there is going to be a State of Men's Heart webinar where our own director is going to be participating, so I'm encouraging you to join and listen in. And Dr. Frieden is not with us in person, but he's with us in spirit, and we'll have a couple of taped comments.
Nearly 1 in 3 American adults, that's 67 million people, have high blood pressure. More than half of them don't have it under control. That includes people who have health insurance and who've seen a doctor at least twice in the past year. The bottom line is this: high blood pressure is out of control for way too many Americans. There's some common lessons for how to deal with this effectively. First, simple quality measures reported monthly to every single provider can lead to big improvements in just 1 year. Second, health IT, health information technology, can be key to success. Doctors and other healthcare providers want to provide good care, and IT can make quality improvement much easier. And third, team-based care, so every member of the team does their part to help manage blood pressure. The good news is that when clinicians, healthcare systems, and patients focus on high blood pressure, they can get it under control and do so quickly. Large and small practices, in rural and urban areas, in the private and public sectors, all can drastically improve the number and proportion of patients who have their blood pressure under control. Controlling high blood pressure is one of the keys to the Million Hearts Initiative, which will prevent 1 million heart attacks and strokes in the next 5 years. We're already seeing results. Today, we'll hear how public health and clinical care experts can work together to control blood pressure. Controlling blood pressure can probably save more lives than any other single clinical improvement. And, perhaps even more importantly, by getting systems right to control blood pressure, we'll learn to improve care in many other areas. Thank you very much.
Good afternoon. I'm Janet Wright. I'm Executive Director of Million Hearts, the HHS initiative you've just heard about, co-led by CDC and CMS. My job today is to share with you how the worlds of public health and healthcare are coming together to bring the nation's blood pressure under control. We're going to start with some physiology. As the heart contracts, blood is ejected out into the arteries under force. That force pressing against the wall of the artery is known as blood pressure. Blood pressure is expressed as two numbers, the top, or systolic, being the pressure when the heart squeezes, and the bottom, or diastolic number, when the heart relaxes. The pressure varies minute to minute in response to stress, activity, joy, and other factors. But elevated, sustained pressures over time can damage organs, key organs, the brain, the heart, and the kidney. Here you see the range of blood pressure readings from normal, less than 120 on the top and less than 80 on the bottom, to the abnormal readings, at risk and high. African Americans develop high blood pressure more often than Caucasians or Mexican Americans, and at an earlier age. And among African Americans, more women than men have the condition. Cardiovascular disease accounts for the largest proportion of inequality in life expectancy between whites and blacks. But the take-home message here is that 1 out of every 3 adult Americans has this highly treatable condition known as high blood pressure. The condition, which I remind you is highly treatable, is the cause of death of hundreds of thousands of Americans, our friends and our family members, every year. More commonly than not, people with other serious conditions like heart attack, stroke, and heart failure have high blood pressure as well, doing its harm in the background. And that harm extends beyond the individual to the economy, to the tune of $47.5 billion spent annually on direct medical expenses. Here's a current snapshot of where we are in the United States in regard to blood pressure control. Fewer than half of Americans with hypertension have it under control. That is defined as less than 140 on the top and less than 90 on the bottom. And of those 36 million uncontrolled, 14 million don't even know that they have high blood pressure. And 16 million know they have it, they're actually taking medication for it, and are not yet under control. You might be surprised to learn that of the 36 million people with uncontrolled hypertension, 32 million have a usual source of care, and 30 million are insured. 14 million of those folks are covered by Medicare. And most of the uncontrolled have been to their usual source of care more than twice in the previous 12 months. These numbers represent a ripe opportunity to improve outcomes and to, in fact, prevent heart attack and stroke. Why are we in this fix with uncontrolled high blood pressure? There are many reasons, and a few of them are listed here. Some relate to the individual with high blood pressure, and others to that person's health care or the environment in which they live. Because hypertension causes no symptoms, people find it hard to take a medication regularly or find it hard to practice healthy habits like choosing lower sodium choices or exercising daily. In brief office visits, clinicians typically address the most pressing issue for that individual patient, and that's often not high blood pressure. Because of the variability of blood pressure readings really from moment to moment, treatment decisions need to be based on not one or two checks in a busy office visit in an abnormal environment, but on patterns of readings. And then finally, our care model is not really designed to get out in front. It's designed to rescue and respond. And we're just beginning to find ways to reach out proactively in a true preventive mode to keep these events from occurring. And then finally, true resistance of hypertension is only present in about 9 or 10% of the population. Resistance is defined by uncontrolled pressures in the presence of 3 classes of antihypertensives, one of which is a diuretic. Here you see the reason why we think hypertension control is so critically important. It's because it leads directly to heart attack and stroke, heart failure, and kidney failure. People with high blood pressure, uncontrolled, are 4 times more likely to die from a stroke and 3 times more likely to die from some form of heart disease. 68% of people who have a first heart attack, 77% of those who have a first stroke, and 74% with chronic heart failure have high blood pressure. And cardiovascular disease, as mentioned before, remains the #1 cause of preventable death for older Americans, but is too often the cause in younger citizens as well, with over 1.5 million events per year and 800,000 lives lost. The trauma to families and communities is devastating, and the cost to the U.S. economy is as well, $312.6 billion every year. It's more than $1 billion a day in direct cost and lost productivity. For these reasons, Million Hearts was launched in September of 2011, a national initiative co-led by CDC and CMS that is focusing the efforts of federal agencies, states, regions, communities, and individuals on the explicit goal to prevent 1 million heart attacks and strokes by 2017. The design of Million Hearts, shown here, harnesses public health and healthcare to change both the environment in which we live and the healthcare on which we rely. Community or population level work is focused on reducing exposure to smoke, increasing the availability of lower sodium choices, food choices, and eliminating trans fat in the food supply. Clinical efforts are aimed at achieving excellence in the ABCs, shown here, through health IT, effective teams, and care models that recognize and reward performance in the ABCs. The ABCs were chosen for their impact in the 5-year time frame on outcomes, as demonstrated in this next slide by the work of Dr. Thomas Farley and team. Implementing the ABCs to their fullest extent can save thousands of lives in the U.S. each year. You can see the effect of each of the ABCs is impactful, but please note that blood pressure control rates of 80% or greater means more than 60,000 lives saved each year. Can such high rates of blood pressure control actually be achieved? Yes, it can. Now, you see on this slide that over the last 2 decades, the United States and the United Kingdom have made steady gains. But look what happens when blood pressure control becomes the focus of collaborative efforts across public health and healthcare sectors. Canada has eclipsed other nations, and in record time. Because of its prevalence, its impact on health, and leading examples of success like Canada, Million Hearts is focusing first on the goal of control. Here you see the performance, the leap in performance that Million Hearts partners, federal, state, and local, intend to make by 2017. These goals are audacious, but they are achievable through the focused efforts in homes, communities, businesses, and clinical settings across the country. At baseline across the population, you see that we're not achieving even 50% yet on the ABCs. To prevent 1 million heart attacks and strokes, Million Hearts has set a 65% population-wide target for each of the ABCs, targets that include people without a usual source of care. Clinical systems are going to have to get to 70% in order to achieve that goal. Here you see the Million Heart Strategies to achieve blood pressure control for the nation. And as you see, this work belongs to each of us, individuals, public health and clinical care experts, and the communities and organizations that we belong to. Reducing the population's intake of sodium will have a profound impact on blood pressure control rates. Better detection and control, leaving no one unprotected from elevated pressures, and better self-management will ensure a normal range and a normal pattern of blood pressures 24/7. But I want to focus now on this fifth strategy as critically important to driving progress in blood pressure control. The first step to excellence in the selection is the selection of measures that matter, standardized measures that are tightly correlated to the desired outcomes. With numerous public and private partners, Million Hearts has adopted a uniform set of these measures, including the National Quality Forum measure listed here for hypertension. This measure is now embedded in multiple programs across the landscape, some of which are listed here. These are programs with reach, programs that will recognize and reward performance, and programs that will help prevent heart attack and stroke. Measures alone, of course, are not sufficient to get to the goal. Getting the nation's blood pressure under control will take focus, technology, and teams, essential elements that create the infrastructure for success. Leaders who prioritize blood pressure control establish the systems necessary to measure and provide timely feedback on progress, and sustain that progress over time by recognizing and rewarding value. Well-designed health IT can serve up action steps for busy clinicians and their patients, so no opportunities are missed and well-informed decisions are made. Teams working together across community and clinical settings, operating off a common script, can support the practice of healthy behaviors, including the wise use and consistent use of medications. And those teams can help patients become the primary managers of their conditions, knowing that help is just a phone call, an email, or a text away. Here's the framework for capturing and building out the powerful alliance of public health and healthcare. You've heard the importance of NQF-18, a population health measure focusing clinical systems on high performance. In services, innovative teams are transforming care delivery. And in drivers, partnerships and payments and partners are all aligning to move the needle. You're about to hear compelling examples, promising pathways to blood pressure control for the country. Our speakers will show how focusing on control, deploying health IT and cross-sectoral teams can turn data into action and action into better cardiovascular health. And you'll see in all three presentations that the solution to our national pressure problem rests in a successful synchrony of public health and healthcare. Pleasure to welcome now Dr. Michael Rekatz. I'm going to scoot this over. Yeah, thank you.
Good afternoon. I'm Michael Rekatz. Until last March, I was the Vice Chair for Quality in the Department of Family Medicine at North Shore University Health System. My talk today is about our efforts to eliminate undiagnosed hypertension by providing detection of hypertension using electronic screening. North Shore University Health System is located in metropolitan Chicago. It's composed of more than 800 physicians, a medical group with multi-specialty and primary care, 4 community hospitals, and a research institute. North Shore's principal teaching affiliate is the University of Chicago. The first question about hypertension we asked in June of 2010 was, is undiagnosed hypertension a problem in our system? To answer it, we performed a retrospective analysis looking back from June of 2006 to May of 2010. Blood pressures at North Shore are measured at every office visit. We looked at adult patients in our system with elevated blood pressures during 3 or more visits, no hypertension diagnosis in their electronic health record, who were not prescribed blood pressure medication. The analysis was conducted as an electronic query using data stored in electronic health records and Enterprise Data Warehouse. The North Shore Enterprise Data Warehouse is a unified database that stores and makes accessible data from across the healthcare system. As a result, the analysis took only hours to complete once the query was written. We identified 150,000 adults with at least one visit to a North Shore primary care provider during those 4 years. 27,000 of those patients already had a diagnosis of hypertension in their EHR. However, 6,248 of the patients met criteria for having hypertension, but were undiagnosed and untreated in the EMR. An additional 3,177 patients were diagnosed with hypertension, but not treated. In total, we identified more than 9,400 untreated patients with hypertension. Eventually, 88% of these patients were diagnosed with hypertension. However, from the time of the third occurrence of elevated blood pressure, there were 17,000 missed opportunities during office visits to make a diagnosis of hypertension over the 4-year period. Our data was consistent with data from other medical groups, clearly demonstrating that physicians miss opportunities to make the diagnosis of hypertension in patients with multiple elevated blood pressures. This is not a problem unique to North Shore. This is happening in most healthcare systems on a global scale. So the next question we asked was, can we eliminate undiagnosed hypertension in our healthcare system? That is what we set out to do. We designed a quality improvement project that would lead to a better screening approach to identify patients at risk for hypertension, increase accuracy and reliability of office blood pressure measurements, better recognition of at-risk hypertension patients at the point of care, and culture change around the use of clinical decision support tools and quality improvement, including administrators, office staff, and clinicians. The project is called the North Shore Undiagnosed Hypertension Quality Improvement Project. The pilot study was conducted from January through June of 2011. We included adults aged 18 to 79 who were seen by North Shore primary care physicians in the previous 24 months. We used all of the blood pressure readings taken within 1 year of the most recent office visit in both primary care and specialist offices. Patients with an existing diagnosis of hypertension in the EHR were excluded. To maximize benefits, we focused on health information technology. North Shore has an integrated electronic health record system-wide. We established a dedicated informatics team to help us extract data, create point-of-care alerts, and develop non-disruptive workflows. Data extracted from an integrated EHR, coupled with actionable point-of-care alerts and non-disruptive workflows, has the potential to be a powerful population health management tool. We accomplished this querying data from our EHR using 5 unique algorithms to identify patients with elevated blood pressure who may have hypertension. The algorithms were derived based on accepted clinical practices, guidelines, and research literature. We call them the North Shore hypertension criteria. Here are the 5 North Shore hypertension criteria algorithms. A few examples are number 1 and 2, patients whose 3 most recent encounters yielded a mean systolic blood pressure greater than or equal to 140, or a mean diastolic blood pressure greater than or equal to 90, and whose reading at the most recent encounter either was or was not elevated. Another example is algorithm number 4, which identified all patients who had 3 encounters with a systolic blood pressure greater than or equal to 140, or a diastolic blood pressure greater than or equal to 90, within the 12 months prior to the most recent office visit. Using all 5 criteria, we identified 1,586 adults we suspected had hypertension, but were not diagnosed. Any patient satisfying at least one of the North Shore hypertension criteria is placed on a list for being notified to come into the office for additional blood pressure measurement. Primary care physicians review their patient list for accuracy to determine if outreach is appropriate. Telephone calls and letters are then used to notify patients they may be at risk for hypertension and to urge them to schedule a follow-up appointment. For follow-up appointments, we use a standardized sequence of automated office blood pressures. We did this because manual office blood pressures are fraught with error and not reliable. As a result, office blood pressures do not correlate well with daytime mean ambulatory blood pressures, which are more highly predictive of morbidity. Both observer and patient errors are reduced using our protocol, as well as the white coat effect. White coat effect is blood pressure elevation that occurs specifically due to the presence of a clinician or office staff. We believe that more accurate and reliable blood pressure measurements will reduce clinician hesitation in both making a diagnosis of or modifying treatment in a patient with hypertension. So what exactly is an automated office blood pressure visit, or AOBP visit? It's a standardized visit used for increasing the accuracy of diagnosing hypertension in patients with multiple elevated office blood pressures suspected of having hypertension. It includes appropriate sizing and placement of the cuff, proper positioning of the patient, physicians and staff who are trained in proper use of AOBP, and patients being left alone in the room during blood pressure measurements. 6 readings are taken by the machine at 1-minute intervals. The first reading is discarded and the remaining 5 are averaged to give the AOBP mean, which better correlates to daytime mean ambulatory blood pressure. As a fail-safe for patients who are not seen specifically for an AOBP visit, electronic best practice advisory alerts were created to fire at the point of care for any patient who satisfies any of the North Shore hypertension criteria. These clinical decision support alerts fire in real time during office visits with primary care providers for both clinical staff and physicians. The goal is to better identify all patients who are at risk for hypertension during every office visit. Here's a screenshot showing how clinical staff putting a patient in an exam room are alerted to measure the patient's blood pressure using AOBP. And here's the alert a physician would see if a patient satisfies any of the North Shore hypertension criteria during an office visit and needs AOBP testing. We went live with the project across all North Shore primary care offices in January of 2012. In the first 8 months, 435 previously undiagnosed and untreated hypertensive patients were diagnosed directly related to the use of algorithm alerts and confirmatory AOBP readings. For patients meeting any North Shore hypertension criteria triggering recall to the office, 97% now have a diagnosis in the electronic health record. North Shore sees nearly 10,000 new patients a month, and in spite of that growth, the percentage of diagnoses on the chart is holding. Most of these newly diagnosed patients with hypertension have significant blood pressure elevations. As a result, lifestyle modifications are recommended, and 94% of these patients are prescribed medications. We now know that screening for patients with undiagnosed hypertension using EHR data combined with electronic alerts at the point of care is effective and has potential to permanently eliminate the problem of undiagnosed hypertension patients hiding in plain sight. Physician behavior can be impacted through identification of a clinical problem, clinical decision support tools, and non-disruptive workflows. EHRs and electronic screening can identify silent but clinically important conditions efficiently. Because 72% of office-based physicians in the United States currently use EHR systems, there is potential for systems like the North Shore hypertension criteria and point-of-care alerts to be incorporated across all organizations using EHRs. Imagine the impact that could have on this problem. Our next speaker is Dr. Peter Bash.
Good afternoon. I am Peter Bash, and I will talk about efforts of a large health system towards improving hypertension control. MedStar Health is the largest not-for-profit health system in the Maryland, D.C. region. It is comprised of a research institute, community hospitals and academic medical centers, and other healthcare facilities. Our more than 5,000 physicians and 30,000 staff took care of more than 160,000 admitted patients and 1.5 million outpatient visits in 2012. MedStar Health is the largest provider for graduate medical education in the region and is a robust clinical research environment ranking in the top 10% nationally in NIH funding. Our primary care network consists of providers and settings ranging from large urban hospital clinics to rural small office settings, with most locations in or around Baltimore, Maryland, or Washington, D.C. All of our primary care providers work under the same enterprise-endorsed guidelines for preventive screening and chronic care management, and all are using the same electronic health record. Early in 2012, MedStar Health became the first health system to partner with the Department of Health and Human Services in their Million Hearts initiative of working to improve adherence to the screening and treatment guidelines for these ABCs of cardiovascular risk reduction. And now focusing specifically on hypertension. You have already heard from Dr. Wright that most people with uncontrolled hypertension have health insurance, a usual source of care, regularly see their doctor, and that most, 22 million out of 36 million, were also aware of their condition. What we have not yet heard about patients with uncontrolled hypertension were their providers aware that they were not at goal or even aware of what their goal was. Blood pressure goals differ on comorbid conditions. Note that people with diabetes, chronic kidney disease, proteinuria, and stroke have a higher than average risk of heart attack and/or stroke, and that it typically requires getting their blood pressure to a goal which is usually lower than the goal for uncomplicated hypertension, less than 140/90, to optimally reduce that risk. Where patients have more than one of these conditions, the lowest goal is typically applied. And to the point of individualized goal setting, note that almost 40% of our patients with hypertension have a comorbidity such that their blood pressure goal is not less than 140/90, but rather one that is significantly lower. I mentioned earlier that all of our primary care providers follow the same guidelines and use the same EHR, but did our practice reflect that? We did not have a screening problem, as our adult patients typically had blood pressures recorded every visit, far exceeding the USPSTF blood pressure screening guidelines. However, it was not possible to tell if we were setting guideline-driven blood pressure goals, as goals were not being recorded in the EHR. This lack of goal setting and the lack of display of blood pressure reading compared to that goal may indeed be the cause of lack of provider awareness. And as providers typically inform their patients of their blood pressure goal and whether or not they are at goal, it may also be the cause of lack of awareness in patients. As mentioned previously, this is of particular importance to the nearly 40% of our patients with pertinent comorbidities that give them a higher than average risk of heart attack or stroke and a blood pressure goal less than 140/90. As our blood pressure screening rates were close to 100%, the primary intent of my design was to embed automated blood pressure goal setting and to increase awareness of both the provider and patient when blood pressure was not at goal. We wanted to prompt providers only when necessary to not add to so-called alert fatigue, and thus only prompt providers if key information was missing, out of date, but always in instances when blood pressure was not at goal. However, we also wanted to always make patients aware of their blood pressure goal and their latest reading, even when they were at goal. We felt this was important for patients to see. This requirement to not add to alert fatigue to providers and always provide relevant information to patients led to our building separate decision support for our patient report card and for our provider view of unmet care opportunities. Here's our approach to increasing patient awareness. On the left is one of the posters on display in our primary care reception areas. And on the right is an example of a patient-specific report card which every adult primary care patient receives at least once a year. Note that this patient has in this written summary her latest blood pressure reading, her blood pressure goal, and a clear statement that she is at goal. Where blood pressure is not at goal, the patient is also unambiguously advised and given clear advice as to how to get to goal. And here's what nobody sees: the smart but very busy form with embedded algorithms and calculators that opens in the background of every adult medicine visit and automatically determines optimal blood pressure goal. This goal setting could, of course, be done manually, but as previously mentioned, it was only rarely being done. By putting the EHR to work as a member of the care team, blood pressure goal setting is automated and thus consistently done. Here is an example of what a provider and patient might view together during a typical office visit. A protocol that needs addressing by the yellow indicator in the upper right. Clicking it shows whatever care opportunities are unmet, which in this case is just one or more goals within our Million Hearts initiative, which when launched shows this Million Hearts global prompt with pertinent prior information and which goals are unmet. Launching the specific blood pressure prompt opens what you see here. Appropriate information is seen by both provider and patient, and depending on what the provider determines to be the course of action, the provider can take that action and document it very easily, typically with only a few clicks. So how are we doing? This provisional report from early in this calendar year shows data from our 8 entities that have primary care providers. As expected, most of the patients have blood pressure recorded, and most have blood pressure goals recorded, and thus provided to the patient. The preliminary results suggest we have already moved the needle on the percentage of our patients whose blood pressure is less than 140/90, but perhaps most importantly, we have for the first time an indication of which of our patients are at their individualized goal, and which of our providers appear to be more effective than their peers in managing hypertension to their patient's individualized goal. While we are a large health system, I believe our panel of patients with hypertension is similar to that of other health systems and small practices. Namely, hypertension is very common, and a sizable minority of patients have one or more comorbidities, making it necessary to individualize blood pressure goals. Prior to this Million Hearts partnership, we were not setting patient-specific blood pressure goals and thus not communicating goals and at-goal status to our patients. We were able to leverage our EHR and meaningful use implementations to embed a complex yet highly usable system such that much of the background work was automated, including always providing understandable information to the patient regarding their latest blood pressure reading compared to their goal. In an unanticipated benefit, while our clinicians are struggling, like many, to find meaningful use truly meaningful, they are fully on board with our Million Hearts program, even though it adds complexity and time to their day. Thank you, and our next speaker is Claudia Stiegel.
Good afternoon. I'm Claudia Siegel. I'm the Director of Health Information and Improvement at the Philadelphia Department of Public Health. While cardiovascular mortality continues to decline in Philadelphia and the nation, Philadelphia's cardiovascular mortality rate continues to exceed that of the nation, as in many cities and counties, cardiovascular disease is the leading cause of death in Philadelphia. We may be similar to many cities and counties with respect to causes of death, but a recent study done by the Institute for Health Metrics and Evaluation at the University of Washington showed that among the 10 most populous counties in the nation, Philadelphia has the highest hypertension prevalence and the highest rate of uncontrolled hypertension. The data on the slide are from a household survey that is performed for southeastern Pennsylvania. Our challenge in Philadelphia is to gather the information needed to make change in an environment dominated by large players, intense competition, and fragmented health information sources. We have 5 academic health centers, each with its own health system, including clinics, hospitals, and EHR systems. Several large insurers dominate the market. The Medicaid population is under managed care and split among 4 different companies that contract with providers to provide services. We have a substantial number of uninsured, many of whom find care at the city's more than 30 federally qualified health centers. So here's what we did. 3 years ago, the department was awarded a CDC cooperative agreement, one goal of which was to improve public health data infrastructure. Our principal strategy is to gather, house, analyze, and share more and better data for the entire jurisdiction related to 3 areas: hypertension, cancer screening, and adult immunization. We have started with hypertension. We established the Office of Health Information and Improvement within the Health Commissioner's Office to build the relationships and secure the physical and data-related resources to get the project off the ground. Here is a list of our diverse partners working within 2 working groups, one on policy and one on data and monitoring. But these 2 groups often meet together. Because of the diverse backgrounds of our working group members, we needed to articulate and discuss the respective approaches of public health and clinical services to the problem of hypertension. We needed to achieve a mutual understanding related to data needs. First of all, that more and better data are required than just vital statistics. And secondly, if we all agreed that hypertension in the city was a problem that could be handled more effectively, we had to get better data related to prevalence and control, share the information, and then construct interventions and develop policy to complement our ongoing contextual initiatives, which I'll address in a minute. We used the health impact pyramid to illustrate where the department had already begun to take action effort and have less immediate population impact overall, but they are essential. They are also felt more directly by many of the very people we would like to bring to a healthier status. Where public health and health services may share interests and approaches is in the protective interventions, but this requires shared information, discussion, and consensus. An example of our contextual public health initiative aimed at the base of the pyramid is the department's Get Healthy Philly effort, which with the help of many partners has turned over 600 corner stores into healthy corner stores with fresh fruit and vegetables. We've increased the number of farmers markets and supplemented food stamps redeemed at these markets with additional Philly food bucks that allow the purchaser to get even more healthy food at no additional cost. We've expanded the mileage of the city's walking and biking paths, and we've assisted consumers who smoke to connect to resources that will help them to quit. The data initiative we've undertaken is viewed as a companion effort. At our first meeting with our data initiative partners, we displayed this slide, which shows the end of the health cascade, premature deaths due to cardiovascular
The time is now to change these numbers, and today's speakers have shown us how to do so. Health IT, focus, team-based care, bringing health care and public health together, optimal cardiovascular health. What are the lessons learned from the speakers today? First is sit at the table together, healthcare and public health. Share data. Set a common goal. Monitor the progress and frequently celebrate the success, even the small successes along the way, because this is arduous work to do, but very rewarding. I'll leave you with these thoughts. First, our goal here is to leave no one uninformed. Help spread the word. Leave no one undetected. Know your numbers. And leave no one unprotected. Go for the goal of control. Thank you. We'd be delighted now to take some questions from here in the room, from the airwaves. A request is to please state your name and also keep your question short so we can get as many questions in as possible. Yes, please.
Yes, Harold Jaffe, Associate Director for Science. Thank you for the nice presentations. A question for either Dr. Bash or Dr. Rackott. Can you comment on how your clinicians respond to these prompts? I would think they get flooded with prompts related to cancer screening, immunization, cholesterol control, and lots of other things. So how do you get them to pay attention?
It's a great question, and this is Peter Bash answering your question, and certainly one that all of us need to pay attention to in system design, because one would intuit that providers would not like this. We found, as I mentioned in my last slide, contrary to what we expected, that while clinicians react very negatively to lots of prompts that seem to be focused on data collection, they like this. And in fact, when I showed you a screenshot of our hypertension specific prompt, which has tons of choices to reflect conditions under which a patient might have an elevated blood pressure at that moment, but they're not going to adjust treatment. I said, you know, this is over engineering, let's make it less, let's make it, no, they said this is perfect because it understands and helps us to capture Mike's word, non-disruptive workflow. It actually fits within their workflow, so it helped to support them. So the other part of it, because I have had some clinicians comment, I don't want to see another prompt the last thing I do. I said, you know what? If you set a goal for your blood pressure, for your patient's blood pressure, and you try your hardest to keep it to goal, you'll never see it. Our prompts only appear when there's an unmet care opportunity. So we see it as there, as something to help our docs. And we tell them, your goal as a doctor is not to respond to the prompts, but to respond to the patient. Use these prompts in a way that helps you and your patients.
Yeah, we had a similar experience. One of the things that I think physicians, they're completely overwhelmed, they're short on time, and these alerts don't always help them in their minds. First thing we did several years ago when the quality program was wrapping up was turn off all the alerts because they were all being ignored. And when we brought them back one at a time, we brought them back with evidence, with academic detailing from physicians to explain to them why this was clinically useful and to make the alerts actionable and useful in clinical practice to help them diagnose a patient with hypertension, for example, even though they didn't want to believe it. Once they read the literature, I mean, physicians they still have a really hard time believing that office blood pressures are not accurate or reliable. But once you show them the evidence and they go, oh my God, how can the whole planet be doing this wrong? They see the data, there's study after study after study, they realize, well, maybe there is a better way. You show them the better way, you give them the appropriate alert, you give them the data to back it up, and they like it. But you have to go very slow, and you have to have some wins before you can start rolling out alert after alert after alert. So I think that's one of the keys as well.
And let me just add one other point. Before I built our system, I made sure that we had the clinical buy-in from our clinical leaders at all of our departments as what are the goals that you want your doctors to achieve? Is it just volume? Is it just addressing the chief complaint of the patient? Oh, no. We are signed on as a partner with Million Hearts, which means that we will try our hardest Is it just for patients who come in and say, I'm here for a million hearts visit? No, no. Every adult primary care patient will have their ABCs addressed, if not visit 1, then sometime 3 in the year. So I said, okay, in that case, the prompt of, you'll see a prompt if information is missing or out of date or something is not at goal, is actually in support of their new clinical mission. And I'm glad to say that our clinicians see it that way.
And I don't know how many people in the audience are clinical, but I have to say one thing, that if every primary care physician did everything that they were required to do by guidelines and task force guidelines, the estimate is that it would take approximately 20 hours a day, 7 days a week to get these things done. So if you use these alerts appropriately to help them, if EHRs and computers can help physicians practice better medicine instead of hinder them, it's really gonna take hold, I think. But we have to be very careful about how we go about doing it.
You can tell we're passionate about this, and we could spend the rest of the day on this question, but thank you.
But we won't.
Yes.
Thank you. Please.
Alan Block. I spent part of my career at CDC working on another chronic disease, tuberculosis, which is where Tom Frieden got his start in public health. And Tom did a spectacular job controlling TB in New York City, and he brought in one of the world's experts, Carl Stiblow, and Tom presented all of this great data, and Dr. Stiblow said, well, how many patients did you cure? And I think what Tom was getting at, or Dr. Stiblow was getting at, is how many of these patients actually have their blood pressure under control, not just at a doctor's visit, but permanently. And with tuberculosis, one of the big challenges has been compliance or adherence. And my question is, it looks like you're able to, with your paradigm, push it to 70%. I guess I have 2 questions. One is, how do you do quality control in terms of, can you go on a subset of these patients to their homes or wherever and do measurements of their blood pressure? And secondly, what tools are you using, or what additional tools could be used to measure compliance and improve it? I would suspect to go above 70%, you're going to need to get into some of those compliance issues.
So it's a great question. I think there are many aspects to that question that I want to address. And I think a key one with hypertension is, if those of us who remember in one of the first public health campaigns about blood pressure, the silent killer, this is part of the awareness issue that we try and present to our patients, which is the reason why we have separate patient education. All patients, regardless of whether their blood pressure is elevated or not, receive information about the importance of knowing blood pressure, and if they have hypertension, controlling blood pressure. So it's part of a visit now, is making sure that patients understand the issue. I think that because we are fortunate that most of our patients also have a consistent relationship with their primary care doctor, they're monitored over time, and part of what we consider routine primary care now is addressing not just why you're here today, but multiple chronic conditions, which in our patient population, typically 60% of our patients have hypertension, diabetes, hyperlipidemia, and so forth. So we have to deal with issues of diet, exercise, self-monitoring. Can you afford your medicines? Are you taking them every day? This has now become part of the visit. There are other tools that we are beginning to use, but I'll say beginning to, because these are not accurate, I believe, to be used on their own, such as electronic medication adherence data from those who have health insurance to see what are covered, but it certainly can give a suggestion of medication adherence. So why don't you add to that?
I'll just say quickly that physicians need to do a much, much better job at explaining to their patient about medications. Approximately 20% of patients don't fill the first prescription that we write for them for blood pressure and other medicines, and up to 40% don't fill the second prescription. And the average amount of time the typical physician spends explaining medication use to their patients is between 20 and 30 seconds. So a lot of the responsibility falls on physicians to do a better job at this, but also I think in the future a lot of responsibility needs to fall on the patients as well and the communities to help the patients better understand and better adhere with the task at hand. And I think home blood pressure monitoring and out-of-office blood pressure monitoring are going to play a much bigger role down the road in communities, not just in the doctor's office.
Could I interject something?
Please.
I think one of the reasons...
Rana Haji, bacterial diseases, immunizations, and respiratory disease. Thank you very much for a very informative presentations. We come from the world of vaccine, where it's easier to control disease, right? One intervention, you get a good impact. So follow up on the previous question. I mean, I see you with the interventions that were presented, it addressed a lot of what can be done on the clinical, both on the healthcare side and on the public health side. Going back to the patient's side, I mean, we all know that just education and increasing awareness is not enough. And I think the example of smoking, programs and control are very good on how policies have actually had most of the impact on addressing the issue. And I was wondering, I mean, we didn't really talk much about policies. I mean, what do you think about the roles of the various policies that have been discussed lately, the issue of salt control in diets and in processed foods and other places, the issues of how much can you ask restaurants and fast food businesses, et cetera. And along this line, I was actually curious about the impressive Canada experience, and I was wondering how much of it was policy and different medical system in Canada versus, clinical interventions. Thank you.
If it's okay with you guys, I will ask Claudia to weigh in on that. Claudia, did you hear that question?
I heard the question, but I'm on mute. I can't get in.
No, we can hear you.
Oh, okay. All right. Pardon me then. A couple of things. We have just embarked on a low-salt campaign, and we are working with our Chinese restaurants in town to lower the salt content of some of the meals, since Chinese takeout food is very prevalent in low-income neighborhoods here in Philadelphia. I think, also in response to the earlier observation, one of the reasons we are working with pharmacists is that we agree that adherence and control are burdens on the physician and they're burdens on the patient, but we need to pay more attention as a public health department to community support and what we could be devising in concert with our partners that will help to support the efforts of physicians and the attempts by patients to adhere to their medication regimens. I'm not certain that we know what all of those interventions might look like just yet, but one of the things that we are trying here in Philadelphia is to find out what those might be.
Thank you. One more question in the back there. Thank you.
Hi, Patricia Griffin. I'm in enteric diseases here at CDC. I hear the same people saying that clinicians don't have time, that they can't get it all done. And I think you're also saying physicians need to do a better job of educating people. And I'm in a field where we don't have vaccines and patient education is helpful. And I'm also a clinician, and when I'm taking care of patients, I don't have time to give the messages that I advocate giving. So I want to know, in your healthcare systems, what are you doing for other ways to educate patients? Do you have I'm a new hypertension patient curriculum where they go in, they see a video maybe with some other patients, maybe not, they talk to some other healthcare personnel who answers their questions, something other than the physician encounter. It could be supported by the clinician. The clinician could say, I really want you to do this. I'm going to ask if you did it. What else are you doing to really educate patients?
So when you hear the term team-based care being thrown around a lot of people don't understand what that means. And it means different things at different institutions. But the dream of that kind of chronic disease management and team-based care is a nutritionist in an office who can do the kind of counseling you're talking about with diet, an exercise physiologist that can help teach people how to move more. Pharmacists really, I think, are critical. In groups like Virginia Mason, pharmacists manage hypertension. They work at the top of their license. They do as much as they can. And physicians are left to treat patients, make a diagnosis, and then hand off to other skilled people on the team so that it becomes a true team effort. And I think that's the real future. And in those systems where they're optimizing team-based care, it's really working. We all want to have rooms with videos and educators in our offices. I think we're in our infancy in that area right now. Part of the problem is we don't always get reimbursed for that. It's very expensive to do. And a lot of the practice-based research that's going on right now and the grants that are being taken for this are trying to figure out how we can do this cost effectively.
Right, and it's a terrific question. I think it really frames what, at least in my judgment, we need to go through, and I believe we are in terms of making for a better healthcare system, which is understanding the role of payment policy, care delivery innovation, which includes team-based care, thoughtful use of health IT, and one could think, well, how do we affect the space-time continuum? Well, when we look at time studies of busy doctors waste a lot of time doing things they shouldn't be doing. And in fact, there are very thoughtful ways of not just using the EHR as a team member, using the patient and her family members as team members, but thinking about pushing various pieces of information to patients so it's not just structured around a visit. If our goal as a country is, which I think it is, to detect and connect and control hypertension, we frame our healthcare delivery a little bit differently. I think we are making great strides there. And I think that one of the things I'm proud to say that we're involved in is, as this new paradigm is evolving, we can step up to the plate. And as Janet said, if we do a consistent and thoughtful application of existing knowledge, what we know now, we can make a huge difference in a very short period of time. We don't have to wait for the perfect scenario.
Yeah, and we've got to move healthcare from the physician office only into the communities where we can do this in a much easier, more cost-effective way.
And Claudia, would you like to weigh in on that last point?
Well, I could only concur. I think it's really important to involve every possible area of support in the community to do exactly what has been discussed. And again, I'm not certain we know all of the ways in which that can happen. It's a matter of exploring and finding out what works and what doesn't, and bringing people into the conversation to see what they can contribute.
Fantastic. Thank you. Thank you all. I would actually ask now for a round of applause for our fearless, brilliant leader, Dr. Tanya Popovich. Oh, you're thinking, who am I talking about?
Thank you so much. And I have to say that I am amazed. We're 6 minutes over and people haven't left. This must have been really mesmerizing for people. Thank you for coming. Thank you for good questions. And I hope to see you in a month and then in 2 months live again. Thank you very much.